honest, you probably will be. You guys will all bring a third molar case, you say. I want to do it, I want you to assist me, Dr. Nix, or why don't you do one and I'll watch? When you're making this incision, you must. I don't generally say when I teach anything about dentistry. Every patient's different size, different shape, right? So no two cases are really the same, but I really am adamant about this. You must, when you incise over an impacting third molar, sound the bone. Because you have mandible shaped this way, and you have mandible shaped this way. So if you have a mandible that's very, very wide, and the tooth is really impacted on the lingual, you may decide that you want to put your releasing incision straight behind this, but look at, this is wide here, and this is all no man's land. That's the danger zone. Blood supply, lingual nerve, permanent tongue numbness of their life. Other things, bleeding can't stop it. So I'm going to advocate, and I'm going to say you must sound the bone. You might create some bleeding points. This is called sounding in periodontal. Make sure you're feeling bone. And once you do, when you feel that bone there, then you can safely make that cut on bone. And it's usually an oblique releasing incision. It's out towards the cheek for safety's sake, out on the mandibular buccal shelf. Okay? Always sound bone in this region. Very dangerous region to cut the lingual nerve or cut a blood supply that you can't, a vessel, venual or arterial, that you can't stop. That's very good. That's very good. Okay, so don't buttonhole, maintain the integrity, broad at the base if you're going to release, but we're going to do envelope flaps for dentovelar surgery except for special occasions. So where did that suture go? Okay, so somebody asked me earlier, I should have brought a bottle of water, right? I'm talking for 3 hours.
I have a bottle of unopened water.
Okay, well, I don't want to take my mask off since you're closer than 6 feet, but thank you. Give me a drink once we're done with this. Needle driver? Any needle drivers anywhere? Okay, great, thank you. Okay, the needle is swaged. And what swaged means, this is stuck in the circle. If you pull hard enough, it'll pop off. You actually have them in the operating room, pop off swaged needles. You pull them, you just pop them off, and you can hand tie the rest. But you want to grab this, I would say, at about the junction between the second and third, if that's the beginning of it. Because if you squeeze the swaged end, this might accidentally pop off. I'm going to palm it. And somebody said, what if this gingiva is really thin? How do I close it? When I do that, it tears, somebody told me an hour ago. Well, that happens. So what I want you to do is take large bites. Take large and equal bites. Because if you take a small bite on one side and a large bite on the other, let's say you take a small bite on this side and a large bite on the other, when you approximate the tissue, it's going to line up like this. But if you take equal bites, it's going to line up equally on both sides, especially if you've done a biopsy and you want to create a perfect closure edge to edge. Here we're talking about using the dental alveolar socket as a wound healing model. So there's a hole there. And I talk a lot in my lectures about wound healing. So anyway, let's enter. Let's grab a lot of keratinized tissue, okay? This is usually a 3/8 circle is what this is. So go ahead and push through and rotate, okay? And rotate. And then you can gently grab the swaged end and push. And then roll your wrist. If you pull straight through, you'll rip right through that. So that's pretty good. So that's what? 3 to 4 millimeters. Now in a perfect world, you can, when you go through this, I don't know if this will do it. If these are,
It goes.
Does it?
Yeah.
It does go?
The space is only on the maxilla, not on the
Okay. Well, let's pretend that that space was there. So we're pushing through, and I like to get it in 2 bites anyway. So let's make sure that where we enter on the other side is also about 4 millimeters, okay? About that. Let's see if I can roll my wrist and get it coming through that gap there. We want this, unfortunately, this is very unrealistic. It'll be more realistic when we do this, right? So, you know, that wants to be down in the embrasure space, not over the contact. Do not do it that way. Okay, but that's the point. So, the amount of suture, better for the, thank you, better for the maxilla. The amount of suture that you want to come out of the mouth is just enough suture to go past the commissure of the lip. Whereas if you have this big gap of suture hanging out and you cut it off, you've wasted all your suture. Okay? And in the maxilla, or when you're suturing, here's what you want to do. It's okay to not do it always, but this is the perfect technique. Isn't it interesting how I'm taking the instrument outside the front of the mouth? Because the patient's cheek is here and the throat is here, right?
Yeah.
So that's why in the mannequin it's more realistic when you guys are suturing and practicing. We're running out of time, aren't we? So anyway, yeah, you're going to take a big bite here, go through the space. Somebody cut it. They did gingival surgery on this one. Yeah, you go through. It's not going to go through on
This
this
space
side.
is only that side.
Yeah, well, only that side. But anyway, so like that, go through the embrasure space like that. And then, unfortunately, I'm not going to be able to go up and under, I don't think. Maybe I can. I'm going to end up sticking myself here. It's okay in this block if you stick yourself because these aren't real people. Just go wash your hand off. It's fine.